So I'm going to talk about women's health interventions tonight. And I wanted to make a distinction just because I think sometimes we cross over our mission as women in IR with performing women's health interventions. And they really are two totally separate things. I think when you go out into practice, you find an area that services your group. And for me, training under Jim Spies, well, not training under Jim Spies, but being a mentee to Jim Spies, and also my time at Penn to Scott and Rich and others who did women's health interventions had a big impression on me. And so that was a niche that my group could fill. But you certainly don't have to be a woman in IR to do women's health interventions. And that's hence my title. These are my disclosures. And also I'll mention that I have some fictitious characters in my talk in terms of cases. So please don't think those are real. In terms of women's health interventions, there's lots of things that we do for women that we also do for men, but there's some distinct procedures that we perform within the IR space, and I think more to come. But some of those include uterine artery embolization, of course, pelvic venous disease therapies, and also fallopian tube recanalization. Again, there are others, but a lot of them have crossover with male interventions, and then some newer things like, foreign body removals in terms of contraceptive devices and things like that. I'm really going to focus on uterine artery embolization and pelvic venous disorder therapies tonight, but I just wanted to give us sort of a grand overview of those things that we're doing. So uterine artery embolization, one of the reasons why I enjoy it so much, and it's one of my favorite procedures, is that it has a lot of utility. Not only does it treat fibroids like it is most known for, but also adenomyosis. It can be used in a preoperative fashion. It can be used for postpartum hemorrhage of a couple of different flavors, and also for malignancy when a patient can't leave the hospital because of vaginal bleeding. Obviously, the most familiar is UFE, so uterine fibroid embolization. And just quick review of some of the pros of uterine fibroid embolization is that it's one of the very few global treatments for all fibroids, right? A woman can have a hysterectomy or they can have a uterine artery embolization. Most of the other treatments, sort of with the exception of medication, are not global. It's uterine sparing, which is shown to have some benefit in addition to just the psychological benefits. More recently, it's efficacious. So it's one of our most efficacious procedures that we do within the IR space. Most women improve with this procedure. In fact, 90% or even more. And the recovery time is short. So there's a lot of pros when it comes to uterine artery embolization for fibroids. This is what we expect to see. And I'm not going to go into a lot of detail about the general overview of fibroids, but when we do a fibroid embolization, the reason why it works so well is because fibroids stump blood flow. So this is a flow-directed embolization, and that allows us to treat the fibroids, but keep the uterine myometrium normal, essentially. And again, it's very efficacious. And on the left, you'll see our initial images before UAE, and then our post-UAE images at 3-month follow-up. And you can see we have a great deal of volume reduction in the fibroids, and they're no longer enhancing. And that's what we expect to see from uterine fibroid embolization. But of course, there's controversies around uterine fibroid embolization, and that's what I'm going to talk about tonight. And so, your OBGYN, especially different generations of OBGYNs, will ask you some specific questions about the contraindications to fibroid embolization. And you really have to educate them at your institution as to how you overcome those challenges. So fibroid location is a big one. They'll ask about submucosal fibroids and whether you can treat those and if it's safe, and pedunculated Sub-Serosal fibroids as well. And then, of course, the fertility subject. One of the other ones that comes up sometimes is, how big of a fibroid can you treat? And we'll talk about that too. So when it comes to location of fibroids, we do have some areas that are more at risk than others. And so we really turn to our FIGO classification or FIGO classification for that. Those types in the 0, 1, and 2 locations, so the submucosal location, and particularly those that are pedunculated, and then the type in the Sub-Serosal location, especially when pedunculated. With regard to submucosal fibroids, the main issue is the attempted passage, and which can lead to endometritis and possibly a secondary intervention, even could lead to a hysterectomy. And so you see on the top, these are pre-embolization images where you have a very large submucosal fibroid that is a bit risky. Doesn't mean fibroid embolization can't take place or shouldn't take place, but it should take place with a discussion. You can see in the bottom images, this fibroid trying to pass. And I had some great images from Georgetown, actually, that I didn't capture, but of something similar. And this does happen. And, at worst case scenarios, patient could end up infected and go down the path that I mentioned before. But even patients who don't end up infected, they can deal with a sort of chronic, very life-limiting discharge. So it's something to counsel our patients about. With regard to pedunculated subserosal fibroids, I really like this publication from JVIR a few years ago. It's a retrospective study, but it looked at about 1,000 women with fibroids and who underwent fibroid embolization. And they were able to parse out about 66 of those that were these more high-risk fibroids. Those are the ones with the stalk that's 25% of the diameter of the fibroid or less. And when looking at these patients, now the follow-up wasn't incredibly long, but when looking at these patients in a median follow-up of about 100 days, some extended past a year, there were no complications as related to the pedunculated nature of the subserosal fibroids, even in that very, very high-risk narrow stalk category. Of course, the concern and what you'll hear from your OBGYNs is, will these torse and expel into the abdominal cavity? And I'll emphasize that there are cases of that. In fact, I've presented this slide before, and I've had someone come up to me at SIR and say, I actually witnessed a patient who had this occur. And so it's not to say that it doesn't happen. I think it's unclear whether it's fibroid embolization that sets the patient up for that, or whether it's the narrow stalk to begin with, that whether they undergo fibroid embolization or not. But also, it's incredibly rare. It definitely falls into that very, very uncommon complication of a pedunculated subserosal fibroid. I think what's interesting about these images is it shows you why the likelihood of it doing that is low. And that is that at least the speculation or the hypothesis is that the pedunculated stalk actually stays enhancing similar to the rest of the enhancing myometrium. So the thought is, why would it detach or necrose and detach if it remains enhancing like the myometrium? And I think that's a relatively good hypothesis. One of the other categories that's a controversy in UFE is fertility. And this is a big one. Every patient's going to ask you about it if they're interested in preserving fertility. Your OBGYNs will keep patients from coming to you, not intentionally, but because they suspect that you wouldn't be able to care for them if they desire future fertility. What's interesting about this is that discussion is really based solely on Mri et al. Studies. If you look at the UFE literature, there's been a fair amount of, thousands of patients have been compared with regard to UFE and hysterectomy, but there's very limited data when you compare UFE to myomectomy, which are really more apples to apples, as Elizabeth Stewart put it from Mayo in her commentary in the FEM trial. Myomectomy and uterine artery embolization, while they have some, dissimilarities, one of the things that's similar about them is they're both uterine sparing. So it's really more interesting in some ways to compare these two therapies when a woman is seeking a uterine sparing intervention. But there aren't a lot of patients who have been compared prospectively in this manner. So it's on the order of hundreds rather than, like I said, thousands who have been compared to hysterectomy. One of the studies that did that was the Mri et al. Study, which is what most OBGYNs quote to suggest that myomectomy does a better job of preserving fertility than UFE. What's interesting about that is Mri et al. Also published a study several years later that compared UFE to laparoscopic uterine artery occlusion, not to suggest that's a common procedure that's done, but it gave us some additional information, I think. And when you look at these two, on the left is the initial study that compared myomectomy and UAE, and on the right is UAE to the laparoscopic uterine artery occlusion. And when you look at this, it really makes it confusing in terms of trying to estimate what is our pregnancy, delivery, and abortion rate with UAE, because even with the same authors and a similar study design, you had a very wide range of what the pregnancy rate was, what the delivery rate was, and what the abortion rate was. It's very it was inferior in the study on the left of screen and somewhat similar on the study on the right. But this is where really all this discussion is generated from. And I'll say that if you look at the study design, particularly of the one that compares to myomectomy, they utilized some criteria that don't really make a lot of sense. For instance, patients who had a certain size fibroid at follow-up, regardless of whether they had symptoms or not, they went on to the myomectomy arm. So, the cutoff, I believe, was 6 centimeters, regardless if it had been 10 centimeters before and shrunk to 6 centimeters. And if they were asymptomatic, they still went on to myomectomy. So there's some biases involved in the study. Later came the FEM trial, which was published in the New England Journal of Medicine last year. And their outcome was not to look at pregnancy rates, but they did, it was a secondary outcome of the study. And you can see here, they're quite dismal, both for uterine artery embolization group and the myomectomy group. And if you look at the second row, is really those women who desired pregnancy, at least at the time of entering this study. We just have such limited data on women who want to become pregnant and are involved in studies regarding UFE. But in this study, just similar to, some of the Mri et al. Data, they really, in fact, UFE did a little better here, not significantly, but really doesn't seem to be inferior to myomectomy. So fertility, what I tell patients is it's hard to study women. Usually at the time they enter these studies or the time they have a UFE, they're not at their prime, time in life to have a baby. Most of the time they're in their 40s. It's not ideal. There are many confounders to the studies that have been done. I personally, my opinion is that global embolization of the uterus likely has some negative impact on fertility. I don't think it's drastically different than myomectomy. And UAE is certainly not a method of birth control. And I make sure to tell my patients that we have lots of successful pregnancies after UAE. So again, it's a discussion with the patient, and it really depends on how severe their symptoms are and what they want. Do they want to address the symptoms despite knowing that it may affect and impact their fertility? Turning a little bit to a different subject, but also within the uterine artery embolization space, is adenomyosis. And this is sort of, I think, it's been treated for a long time with uterine artery embolization, but I think it's still up and coming in terms of understanding the data behind it and how best to treat it. This is a case of, pure adenomyosis, not really with much fibroid burden, and it's diffuse. And you can see all flavors of adenomyosis: focal, diffuse, pure, in combination with fibroids. This is a case where the result with uterine artery embolization was quite dramatic. You can see that only the little rind of myometrium remains enhancing because the adenomyotic tissue was so diffuse. And there probably is a fibroid in here that didn't treat all the way. But in any case, it's a pretty robust response. Often you just see some heterogeneity and contrast enhancement post-embolization with adenomyosis, but this was a pretty dramatic response. The thing about the adenomyosis outcomes is we have very limited data. We know that women do better, and overall we have a pretty good result, 83% in the short term. We do think that women who get treated for a combination of adenomyosis and fibroids seem to have better symptom control after UFE or UAE. And, but the key takeaway here is that in the long term, there tends to be more symptom recurrence or seeking a secondary intervention than is seen with just fibroids alone, and that there's no comparative trials. When you talk to some of our colleagues in Europe who have tried to start a comparative trial of UAE and hysterectomy, the issue for them, they have stated, is that the trials have been unsuccessful because women have not wanted to be randomized to hysterectomy or UAE, especially to the hysterectomy arm. So they've converted these to the Questa trial in particular to a retrospective study. So we just have very, very limited data. And you can imagine there's also not a myomectomy type procedure for adenomyosis. There are minimally invasive surgical treatments for adenomyosis, but they're not incredibly effective, and they are done at limited centers in the country. So another way that we utilize uterine artery embolization is preoperatively. This is one of the few instances that I personally do radial access pretty religiously, and also I often do these procedures on the same day as the surgery. And the reason why, this is a patient, I'll just take you through her case example. This is a patient who obviously had a gigantic fibroid uterus. This is a big Sub-Serosal fibroid conglomeration, really. You can see it comes up to the level of her liver and kidneys and splays her mesenteric vessels. And she was a Jehovah's Witness, so she didn't accept blood products. And that's the reason why we were asked to do a uterine artery embolization beforehand to set her up for success for her hysterectomy. The reason why it's so nice to do these procedures on the same day is so that the woman doesn't have to recover from the discomfort of a uterine artery embolization. But if you do femoral access and then the patient goes to hysterectomy and they put them in the dorsal lithotomy position for that procedure, you have to worry a little bit about your groin flexion. So I got to the point where, when possible, I will perform these radially and do send the patient to surgery the same day. This is her explant, and the OBGYN actually sent me this from the OR and said we had about 50 cc's of blood loss. So it works. And, it's a great way to build a relationship with your OBGYN because it's sort of a segue into their trust. Postpartum hemorrhage, there's sort of two flavors of postpartum hemorrhage, the early or primary, and then delayed or secondary. And really what falls within that category is retained products of conception and uterine AVMs. I actually see those to be, in my opinion, sort of a spectrum where I think there's sort of a development from retained products that sometimes leads to a uterine AVM, but that's anecdotal. This is a case of a primary postpartum hemorrhage. So this patient had lost about 5 liters of blood by the time that they called us to intervene. She had a Bacri balloon for, to try to tamponade on her bleed, but that was unsuccessful. And you can see this is her, the catheter up and over into her left internal iliac artery. And you can see this white arrow depicts the very, very diminutive uterine artery. And you can imagine during the peripartum period, this artery should be gigantic. It's very hypervascular. And then, of course, the robust bleed. Vessels never get bigger, they taper. So this is a very profound bleed. And you can see afterwards, once we did the embolization, we checked both sides, of course. And you can see her vessels are starting to plump up on the right side screen aortogram. Of note, you always want to check the other side because of the blood flow that can collateralize, but also sometimes these bleeds come off the large ovarian artery. So you have to check that, and even some other collaterals like the round ligament artery. So it's important to remember that. With secondary postpartum hemorrhage, this is a real challenge, I think, imaging and deciding what to do with these patients. I would say that first I start by usually with an ultrasound, and usually the OBGYN has already done that and often been following a beta level to decide, is this retained products or is this an uterine AVM? And often these, if they're small, whatever they are, will treat on their own. But it's really a really difficult distinction to make sometimes by imaging, yet an important one for the OBGYN. If it's retained products of conception, they may instrument the patient. If it's a uterine AVM, that's the last thing they want to do is instrument the patient. So in a lot of instances, this will start with an ultrasound and you'll see a hypervascular focus. Okay, what is that? And so you may be able to tell by the beta, you may not. This patient often may go on to an MRI. Again, you see a hypervascular focus in the endometrium. What is that? Well, we tried to reconstruct this one and we thought, okay, we can see the uterine artery, and we thought we saw a vein leading away from it. We were almost sure this was the uterine AVM. I can tell you, I guess wrong a lot on these. And so do our diagnostic imagers. When I took this patient to angiography, it was clear that there was no early draining vein on either side. I think the right side or the left of your screen showed sort of a abnormal tuft of tissue. The right screen or the left uterine artery was more typical myometrium. So I opted to treat only on the right. And this patient, what I ultimately think they had was retained products of conception. It sloughed off after my procedure. We did a series of these at Georgetown where we looked at all the patients that we took to angiography and whether they actually had a uterine AVM or whether we decided it was retained products of conception. And regardless of what they were, embolization worked. And so all of these patients did not need a secondary intervention, even for retained products, because they just essentially sloughed off the tissue with their next cycle. All right, so we're going to talk about a few cases to kind of apply these concepts of uterine artery embolization into real life. Again, these are fictitious characters. So this is Casey Friedman. She's a 45-year-old female with menorrhagia, and she wants to wear white again. I don't know if those of you who don't treat this or who have little experience with it, some women literally drive to their work 10 minutes down the road, and by the time they get there, they're so flooded that they actually can't get up and go into work. So I always say this isn't cancer. This isn't doesn't have that magnitude, but this is really quality of life limiting for some women. So I think that gives me the inspiration to treat these women and help them. These are her MRI images. You can see a dominant myometrial fibroid and some secondary fibroids, but really her main one and probably the issue for her in terms of her bleeding is this fibroid. And it's got at least heterogeneous enhancement. So we decide to take her to embolization. And I started by going up and over. And so I can't remember actually if this was a femoral approach or radial, but regardless, once you get to the internal iliac artery, it's all the same. And so here's an anterior division injection in an obliquity, and you can see the origin of the tortuous uterine artery very well. Okay, great. We get into that with a microcatheter, and there's lots of different ways, whether you use a macrocatheter or microcatheter, but regardless, when you do the injection, you can see that it fills some of the fibroid, but there's probably some that's missing, right? We saw that it was a pretty spherical dominant fibroid. So we go to the right, and we expect to see the other part of that fibroid, but on my oblique, I see no origin of the uterine artery. So I do a different obliquity or AP. I still see no dominant uterine artery. And so then you have to think about what else do you need to do? And so we do an aortogram. And in the aortogram, the most common, I would say, collaterals that I find are either the ovarian, far and away is most common, but I have actually seen 6 or 7 probably cases of a round ligament artery supplying fibroids. So that's also, and that typically comes from the origin of the inferior epigastric. So that can be seen on and is less conspicuous. So it's one of those ones you have to kind of look for. But in this case, it was obviously a dilated large ovarian artery, and you can see that it fills to the pelvis, similar in timing to the iliac arteries. And then when you get into the ovarian artery, you can see that this very clearly filled the fibroid. So if I had not looked for this, the patient probably would have gone untreated from my embolization. Probably a small portion of her dominant fibroid would have been infarcted. What's interesting is when you go back to my MRI that I had pre-procedure, it was all there. So here's the left uterine artery, and you can see that that was expected to be dilated and hypervascular and supply some of the fibroid. And if you look closely, and that's a left uterine artery, if you look closely, you can actually see the right ovarian artery is large, so it was actually all there. All the information was there pre-procedure. So, don't forget to look at your imaging and have that help you. Next case, let me move my window box here. All right, so this is Jennifer Johnson. She's a 32-year-old female with 2 prior C-sections and tubal ligation. So already ringing to us that maybe she doesn't desire future fertility. We don't have to worry about that. She's got a chief complaint of menorrhagia, and she would like to avoid a hysterectomy. And so these are her initial images, and you can see, one second here, let me get this box out of my way. Okay, you can see that on her fluid sensitive sequences, you can see a couple of fibroids. And I always look at the coronals, I should mention, just because that's really what correlates the best with what you're going to see in 2D when you go into your embolization. So I looked at those, then I looked at the sagittal. And why I showed these images is because in addition to fibroids, she probably has a thickened junctional zone, maybe some degree of adenomyosis. And then on her contrast enhanced images on the far left of your screen, you can see that pedunculated Sub-Serosal fibroid posteriorly doesn't have much enhancement at all, but a little component of it does if you look on the sagittal, which is the second image. And then as you go further over to the right of screen, you see a second fibroid in the myometrial space. Again, both on the axial and on the sagittal, probably doesn't have a lot of enhancement at all. So I debated, should I take this patient to embolization at all? Am I going to be useful to her? And I thought to myself, well, she's got a little bit of enhancement. And I also think that she has a degree of adenomyosis. So let me see. So I decided to take her. And here you see on her right uterine artery injection, you can see that one of the fibroids fills. And I know, but based on looking at her MRI, that was her myometrial fibroid. Okay. So I thought, need to treat that side? Yes. Then I went to her left side. I didn't really see fibroid. That looks like relatively normal myometria, maybe a little splayed, maybe a little hypervascular, but not too abnormal. But I thought, okay, she does have adenomyosis. I'm going to treat that to some degree. So I did. But I knew that there was probably part of a fibroid missing just because I never saw that pedunculated fibroid. And I expected it to have similar enhancement to the myometrial one. So I looked at her ovarian, which is not tremendously large, but lo and behold, it supplied part of that fibroid. All right, and our last case for uterine artery embolization. This is Daisy Cruz. She's a 38-year-old female who's had children, and her chief complaint was also menorrhagia. She had a myomectomy 8 months prior, but had no improvement following myomectomy. And it was a hysteroscopic myomectomy, I should mention. She also complains of bulk symptoms and all the things that go along with that. She had a negative endometrial biopsy. These are her MRI images on the fluid sensitive sequences. And you can see that she has a submucosal fibroid with the majority of it being intercavitary. I believe I have, and contrasted images which show contrast enhancement. So what happened in her myomectomy, more than likely, if you've ever seen a hysteroscopic myomectomy, and if you haven't and you're interested in doing UFE, you might want to tag along with one of your gynecologists to take a look at these. They use a device that essentially, as they chip away at the fibroid, they get fluid imbalances at a certain point. So they can only proceed for so long. So they probably chipped away at this, and it was a relatively large fibroid to a certain point, but then the rest of the tissue that was left behind was still enhancing and active and could cause her symptoms. So this patient is what I consider a myomectomy refractory patient. And so I know it's a high-risk fibroid, but I also know that I can kill it with fibroid embolization. So what I opted to do, and what I've done in many cases, is a combined treatment that I worked with one of our gynecologists on, where I do a uterine artery embolization, and then 1 to 2 weeks later, the patient has the rest of the bulk of the tissue removed. This changes their fluid imbalances. When the fibroid is dead, they're able to chip away at a lot more of the tissue, and whatever tissue they don't get is dead. So it's unlikely that it'll grow back. This patient, again, I always look at the coronal images, which these are a little fuzzy here, but I always look at the coronal images before I go in, just to kind of get an idea of where I expect the fibroid to, what I expect it to look like in 2D. And so this fibroid sort of originated from the right side, but kind of pointed towards the left. And so when I did my angiography, I injected the left side, and I thought, well, gosh, I don't really see fibroid there, but I wasn't sure. So I went ahead and treated that side. It was one of those ones where I was going along and I just really kind of assessed the flow incorrectly. By the time I realized I was at the end point, I was too far, really. And so this endpoint, I wanted to show this case because this endpoint is probably a little bit of aggressive, and everybody does fibroid embolization a little bit differently, but we really want sort of sluggish flow, like a 5 heartbeats in the main uterine artery, and just not to see fibroid branches. This is kind of everything refluxes, and then maybe we get a little sluggish flow in the main uterine artery. So it was a bit of an aggressive endpoint, especially for the side that I didn't really know if it was involved or not. And these are just some still images of that, just in case the video didn't work. This is the right side, the right uterine artery, and you can see the entire fibroid, of course, here. And so, of course, I'm going to treat this side, and I think a better endpoint where you see a little bit more of just that sluggish flow in the main uterine artery, maybe even slightly aggressive on this side, but not quite to the degree as the other. And again, some stills. So this patient is one of my patients that I'll never forget because I had a terrible complication with her. She immediately went upstairs and was in 10 out of 10 pain, couldn't even talk to me, was pinpointing to the left lower quadrant. I was standing at her bedside, just giving her drug after drug after drug with zero improvement, didn't even touch the pain. And this went on for about an hour. I could not get control of it. I called the anesthesia pain team. They actually came and did an epidural bedside. She did okay the first night, and into the next day. This was Saturday, of course. I was not on call. Sunday, I came in just to see her. She was toxic. She became febrile, tachycardic. The pain she could actually still feel it through the epidural. And we drew blood cultures and brought her down for CT. I rarely do a CT after fibroid embolization or any embolization because, as we know, it can be suspicious for infection even if there's not infection, but I had to with her. And if you look here, what you actually see is 2 different things. The fibroid itself has what looks like air streaking through it. That's air within vessel. That's normal. That's what we see with a vascular embolization. But what we also see is this globular-like air around the fibroid. That's not normal. And that was indicative to me that she was very clearly infected in addition to the other things. So she actually did well for a couple of days, and OB-GYN saw her every day, and they were debating whether to do a hysterectomy or not. And ultimately, she decided on a laparoscopic hysterectomy, of which they went to. And I was there, and I'll say that immediately, even looking with the scope, I could see that the uterus was just not pink. It was just not normal. And I think this was just an over-embolization. You can see on the right-sided image, this is the cervix splayed open, so you can see how large the fibroid is. Again, the intent wasn't to do this as a single procedure. She was to go on and have a hysteroscopic myomectomy to follow after embolization within about a week. But regardless, I think this was a case of, a bad scenario, a bad fibroid, which was not successful initially with myomectomy, but also just, likely a misjudgment in the degree of embolization. Remember that when we go back to our FIGO classification, this falls within the submucosal category and certainly very much within the intercavitary location. So in summary, the part about UFE, or UAE, I should say, we'll talk about pelvic venous disorder still. But with regard to UAE, I think, some of my summary statements would be UFE is safe, and I put that in quotations just because it's safe when you consider, what I guess, normal or average percent of complication you're willing to take, right? So I think certainly safe for intramural and subserosal fibroids down to, the less than 1% likelihood of causing a complication, a major complication, I should say. UFE is the second choice, I would say, for sizable submucosal fibroids with a very, very robust discussion of risk assessment, or you can utilize a combination treatment like I have suggested. UFE is not contraindicated in any size fibroid. I know we didn't go into that in great detail, but I think it's about setting expectations with the patient. UAE is offered to women who desire future fertility, but again, with a discussion about those things that we had already. UAE is effective for adenomyosis, but less longevity probably than UFE, and a lot more patients seek a secondary intervention down the road. And UAE can serve as a standalone treatment for both AVMs and retained products of conception. All right, we're going to transition and finish up with pelvic venous disorders. So I put an umbrella here because I think pelvic venous disorders is a newer term. I always think of the artist formerly known as Prince when I discuss this entity because it's, the entity formerly known as pelvic congestion syndrome. And we'll talk about it with those terms still because we all know that language, but we're making a shift to call, use more of an umbrella term for these entities that fall within pelvic venous disorders. And some of the symptoms and signs that go along with these disorders are pelvic pain, chronic in nature, greater than 6 months, leg pain, flank pain, varicosities, whether on the leg or the vulva, and then, of course, hematuria, especially in venous compression syndromes. So when I think about pelvic venous disorders, I try to make it very simplified. I think about, is this pure pelvic venous insufficiency because of valve dysfunction? And in those entities, that just means that the ovarian or gonadal vein or the internal iliac vein are abnormal. And so blood flow goes in the wrong direction. Or is this caused by something obstructing it upstream? Is this a venous obstruction? And when I think about those, again, these terms are older and they're becoming sort of out of vogue, but is it nutcracker or left renal vein compression? Or is it May 3rd and, being left common iliac vein compression? And so I try to put those into a thought process. So again, venous compression of the renal vein, it's going to result in the same symptomatology. And venous compression of the common iliac vein is going to result in internal iliac venous pathology. When it comes to the diagnosis of pelvic venous disorders, I think it's one of the hardest disease processes to diagnose. It's easy if you see it on imaging and the patient has symptoms, because that's really what you need is the combination. But as you all know, often we see reflux on imaging in women who are completely asymptomatic. And often women have symptoms of pelvic venous disease or pelvic congestion that are very clear. And yet when you do cross-sectional imaging or ultrasound imaging, it's not evident. And I think part of the reason for that is it does seem to be somewhat cyclical. Women will describe it as flare-ups. And I do think that sometimes we catch it at the wrong time. I think that cross-sectional imaging, particularly MR, a patient is laying down for a period of time and we're probably not catching everything that we can. And I think ultrasound, while very good, is very operator dependent. So a lot of reasons why we may not catch it. I think the presentation is much more important. These women have a variety of symptoms, but they tend to be women who have had babies, so Paris. And one of the sort of lesser known signs of a pelvic venous disorder is women often have microscopic hematuria, not just in venous compression, but in general. And so those are some things that can kind of help aid in the diagnosis. Embolization is one of the only therapies for pelvic venous disease, particularly for the straightforward non-venous compression syndromes. The problem with it is somewhat similar, I guess, to treating adenomyosis with uterine artery embolization, in that there's not a great comparison. And so a lot of our studies are single arm studies or retrospective studies. So the best information we really have is through systematic reviews. If you look at these, again, while the data might not be incredibly reliable, I think if you look at all of these studies and graph, I love this graph because I think it at least describes a signal. On the left axis is the visual analog chronic pelvic pain score, which is commonly used in these types of studies. And across the bottom is months from embolization. So what I think we can say about most of these studies is that they show a very dramatic decrease in pain score quite quickly and a sustained response. And that's the kind of signal that you see throughout these studies. I like this study, which was actually one of the very few randomized trials in the pelvic congestion space. And unfortunately, it doesn't compare another therapy. It compares two embolization therapies. One was, using coils and as compared to vascular plugs. So again, not comparing it to another therapy, but at least giving us some additional information in a randomized trial. The visual analog scale, again, or the graph on the left is, again, the visual analog scale and then months from embolization down below. And again, you see no matter whether it's a fibroid coil or a vascular plug, you see a dramatic decrease in pain score and a sustained response. This particular, the goal of this trial, again, was to compare fibroid coils and vascular plugs. Not the important factor here, but it does give us sort of a range of our expectation of efficacy for embolization, which is anywhere, in the range of roughly 80 to even up to 100% effective. They were not significantly different in comparison. Of course, if you look at other factors like how quickly the procedure was accomplished, vascular plugs went out. But in terms of efficacy, they were very similar. And again, not the key that I want take home here, more just some information on efficacy of doing embolization for pelvic venous insufficiency. But again, there are challenges with pelvic venous disorders and treating pelvic congestion. And the main one is that insurance carriers either don't cover it, which is a very local thing, so a regional thing. So it very much depends on where you are. But also that OBGYNs are honestly not that familiar with vascular etiologies of pelvic pain. They will, if they do know about it, they often say that there are no comparison studies. They think it doesn't affect postmenopausal women, so it doesn't even get on their radar. And they will suggest, in many cases of pelvic pain, let's do a hysterectomy. And even insurance carriers are willing to pay for a hysterectomy for pelvic pain. And the same women, they often won't pay for an embolization. So it's very challenging. This is a letter that I created for my patients because I go through an appeal process in the state of Alabama for almost every single one of my patients. And it's a real challenge. But I specifically, I alter it to be specific to each patient, of course. But one of the very interesting things, and why I'm common on postmenopausal women, is I think, these women do not develop this postmenopausally, but a lot of women have gone through various pelvic pain treatments for years and never found the right etiology. And in my experience, postmenopausal women are still affected by this. And why I put it on this slide in particular is because there's a particular insurance carrier in the state of Alabama that has denied every single appeal that I've made for women with this particular carrier. And no matter what peer-to-peer, no matter what letter, no matter all the data, all those kinds of things, the one that they approved outright was a woman who had a diagnostic lap by the OBGYN, and they took pictures of dilated pelvic veins. And that's how I kind of segued into being able to treat postmenopausal women, because I happen to be the chair of OBGYN at UAB. So it was a great segue into being able to get those patients and find the appropriate treatment for them. So I think when all else fails, unfortunately, some women actually undergo a diagnostic lab. Fortunately, they can keep their uterus if dilated pelvic veins are seen. And that may be the reason or one way to help in kind of justifying this procedure. One of the other things I want to mention is that the American Vein and Lymphatic Society working group has done significant work on developing a common language. That's another one of the reasons why we struggle so much to develop reasonable studies and provide us data in this disease process, because we've never really used the same language across specialties in treating this, or even within our own specialty. And so this obviously looks very complex, and it is a bit complex, but there is an app for that. So these are just some screenshots from the app. If you're treating women, doing any women's health interventions, I encourage you to download this app. I had nothing to do with it whatsoever. But I think, the more that we document this in our clinic notes, and as we come up with registries through the SIR and such, the more that we're speaking the same language and having this in our clinic notes, the more helpful information we can extract from it and learn more about this disease process. So we'll, of course, do a case on pelvic venous disease. So this is Melissa Koss. She's a 41-year-old female with chronic pelvic pain, again, meaning greater than 6 months. You can see her cross-sectional imaging here. She has a dilated gonadal vein. I show this case a lot or similar case to my trainees, and I don't tell them that she has a symptom of pelvic pain, and I always lead them down the path of diagnosis without knowing her symptoms, and I always have to take them a step back and say, no, you've got to know, because you can see this in a lot of women, and there are studies to show this, that there are a lot of women with these findings on imaging that don't actually have the symptomatology. But in any case, this woman did have pelvic pain, and she also has the findings of a dilated left gonadal vein. So my sequence of events, I would say, for doing this kind of treatment or assessing a patient for pelvic venous insufficiency, I go from the groin. I think Rich, if I remember, goes from the neck. I just found that for some reason, women never wanted me to work near their neck. I thought the groin would be a more sensitive region, but they just don't like me working by their head. So I typically go from the groin. I do a renal vein injection to look for venous compression syndrome, and also to kind of assess is there already reflux down the gonadal. Of course, in this case, there was. This is actually a different patient, but I just wanted to give you some understanding of what the sequence of events might look like. Once you're in the gonadal and you do an injection, this is definitely an abnormally large gonadal vein, but still it makes you wonder when you get kind of, equivalent flow a little bit down the gonadal, but most of it goes back to the heart. And it makes you wonder, am I dealing with a disease or not? And so just remember, you have lots of tricks to assess this. Remember, the patient's laying flat. I think it's completely reasonable to put this patient into a little bit of a tilted position to assess this. I will caution you against doing a Valsalva maneuver. I'll tell you that I learned the hard way that you can make any vein Valsalva, so including the entire IVC, and you can cause reflux of anything with a good Valsalva. So just remember, it might give you, an overestimate of disease. Now, I do use a Valsalva sometimes when I'm using a sclerosant so that I can limit it to the pelvis and have it not ascend back into the renal vein. So I think it can be used in that way, but I would recommend over a Valsalva in terms of diagnosis to use a table tilt. This is also another patient, and you can see that the gonadal vein can be incredibly complex, tortuous, multiple channels. And when you get down into that periuterine reservoir, it's not just, it's really never very simple. And so just putting in a couple of coils is probably not going to be an effective embolization for a patient with a periuterine reservoir like this. You really have to get down there and use something that's going to fill that. So I recommend sclerosant in the deep pelvis, and then I use it sort of intermittently as a sandwich technique up the gonadal vein, but most importantly to fill that periuterine reservoir. If I see on injection that everything is going over and actually filling centrally through the right side or opposite side, whichever one you happen to be on, I will add to my sclerosant mixture a very, very dense gel foam to kind of slow things down. But typically I use STS, Lipiodol, and air. And then after I do the left, I always check the right, particularly if I have a high suspicion, and this patient was also abnormal, similar technique. And then you always got to remember to check the internal iliacs, one, because they can be abnormal on their own or can be due to a venous compression syndrome. So here, when I did my injection in the iliacs, I thought, well, gosh, there is reflux. Are these collaterals because of May-Thurner? for venous compression, or is this just abnormal because there's reflux? And so you have tools like getting a pressure gradient and also using IVUS. And in this particular case, this was just plain and simple internal iliac abnormalities. And so I treated that again with a combination of sclerosant and coils. And I really think a lot of times in the internal iliac, you also need sclerosant because of the same thing. It's very hard to kind of get complete embolization just with coils. And so in summary, PEVD or pelvic venous disorders are best evaluated clinically. Again, imaging is not diagnostic. Typical patients with pelvic venous insufficiency have a lot of similarities, but two that I find that are pretty consistent are they're hairless, they've had babies before, and they have often microscopic hematuria. I think VAS scores are greatly reduced with embolization, but of course, as I mentioned, comparison studies are lacking, partially because we have never had the same language, and partially because there's so many overlapping pelvic pain disorders. Postmenopausal women can have pelvic venous disorders, and often they occur, of course, before they become menopausal, but just are underdiagnosed. And payment pre-approval can be really challenging. Consider using the SIR documentation, and in worst case scenario, you may even need an OBGYN to look visually. This is my thank you to you for listening and tuning in. I look forward to questions. And also, I think it speaks to the next generation. This was a thank you card that one of my trainees wrote me, and you can see she actually drew all the letters with wires and catheters that she became familiar with on her IR rotation. So I thought this was super creative. And my contact information for any questions offline after today.
Thank you so much, Theresa. I'm getting some texted over questions and stuff. So one of the questions is, given the cases that you showed on ovarian supply, and then the possible effects that could have, how do you make that distinction in balancing the risk for early menopause or those kind of risks that people talk about with ovarian embolization versus whether you think that it's a significant contributor to the fibroid treatment? So one of the things people ask is, if you had all comers and you did ovarian injections in all of them, you might overtreat, or you might be more likely to find a lot of them that you wouldn't have found, obviously, if you didn't go looking for them. But on the other side, if you did that, you might get into early menopause. So
yeah, it's a great question, and it comes up a lot, and I'll try not to be too long-winded about it. I think, first of all, timing of when you look for the ovarian is important. So if you go in and do an aortogram from the beginning, it's been shown that sometimes you see an ovarian artery, then you do the uterine artery embolization, and you go do an aortogram afterwards, and there's no longer a supply from the ovarian artery to the fibroid. So I think it's important to do it after you embolize the uterine arteries if you suspect additional supply. I talk with my patients about this possibility. I just like to set the stage for it. What we found at Georgetown, and this was really based on Jim's experience, but patients have a copay with all of these procedures and hospitalizations, and we tend not to hospitalize anymore, but still, they do have sometimes a significant copay. So doing this stage, so meaning, doing their bilateral uterine arteries, and then they have to come back because they had residual, fibroid enhancement and symptoms, and then targeting their ovarian arteries was cumbersome financially and for the patient's recovery. So what we started to do was counsel patients, particularly if we saw it on MR, but also just as a general topic of conversation in our consultation. It can be difficult to get through a lot of consultations when you have this in-depth kind of conversation, but I think it's important if that's the way you're going to go. I search for it when I suspect it. Either I have a bad MR where I can't tell, I have no MR where I don't even have the ability to look, or where the patient has had prior surgery. Those are the instances I search for it. And then when I'm actually looking angiographically, if I don't see what I expect to for a woman's fibroid territory, and they, for instance, have a large fundal fibroid, that's very typical to have ovarian supply, things like that. So in some very specific instances, I do not do an aortogram in every patient, really just on suspicion for all those reasons I just stated. There have been studies that showed that, there has been a study that showed that embolizing one ovarian artery does not have a significant impact on sending a woman into menopause. So, it's very uncommon to have all of the fibroid supply from two ovarian arteries, but I have seen it. I have unfortunately encountered it, and those are difficult situations, but that's the reason why the conversation takes place in clinic beforehand.
Thank you. The next question was one related to the adenomyosis, which is, first of all, is there any other besides hysterectomy? It seems that most of these patients are facing hysterectomy versus whatever we have to offer them. I guess if you can expand upon if there is some other additional treatments that they could get. And then the second thing is, I guess that's how the question is usually framed, but then what kind of numbers do you quote in terms of response rates with adenomyosis? And does it matter the extent of uterine involvement?
Yeah. So starting with the first part of the question, oh gosh, I remember the second part. The first part was
whether or not there's actually
other
additional treatments.
Yes. Yes. So women, a lot of women do really well with an IUD. So not so much medication, but an IUD. So that controls often the menorrhagia that they have and helps them with their pain. But sometimes it's not enough. And I find that also women who get a uterine artery embolization for adenomyosis, there are times when it's also not enough. And in those instances, sometimes we'll actually add an IUD after uterine artery embolization, and the combination of the two is effective to control their symptoms. I quote somewhere between an 80 and 90% effective efficacy in uterine artery embolization for adenomyosis. But again, I do see more women needing secondary intervention when you look at the trials, or at least the retrospective studies. And so, probably 2/3 of women don't seek a secondary intervention. And that's sort of the number I use, but that still means that a larger percentage of them do than with fibroid embolization. In terms of other therapies besides an IUD or medication, and of course, besides hysterectomy, there are some centers that perform what they call minimally invasive, adenomyosis surgery, essentially. And they basically go in and hack away at what they think is adenomyosis. But when you look at what they're doing hysteroscopically, it's very hard to distinguish adenomyotic tissue from normal myometrium. And so even the surgeons who do this, tell you how very, very difficult it is. And it doesn't really leave the uterus in great condition to be, I can't think of a better way of saying hacked away at it in several locations and, sutured together. So it doesn't particularly leave the uterus in a very strengthened state. And so, I'm not a huge advocate for that. That being said, I think, for places that have expertise in it, it is a possibility. In terms of what types of adenomyosis respond to uterine artery embolization, there are some small studies on this. Mondo Kim has some studies that show the signal characteristics on MRI might be predictive of how the adenomyosis will respond. In terms of whether, diffuse versus focal adenomyosis responds, I personally have not seen a great signal in that, nor are there really any studies that show that it allows us to be predictive of whether the adenomyosis will respond or not. The only factor really is that the signal of the dark signal on MRI of the adenomyosis tissue itself. I hope that answered all of those components of the question.
Yeah, I think so. For the pelvic congestion syndrome or pelvic venous insufficiency discussion, do you have a treatment imaging modality that, do they all have to get an MRI? I guess is the main point of the thrust of this is do you have, do all of your patients get a pelvic MRI for evaluation prior to coming in for treatment?
Yeah, actually almost none of my patients get an MRI. I have become less and less reliant on imaging for pelvic venous disorders. I don't even necessarily require an ultrasound in some patients, but most patients come with something. They either had a cross-sectional imaging where they went to the ER with pelvic pain and it showed that they potentially have, a dilated gonadal vein, or they had an ultrasound done somewhere that showed there may be reflux. So most patients come with something, but I certainly do not send them for cross-sectional imaging if they don't. I basically, at the point they come to me, often they have eliminated most of the other reasons for pelvic pain, at least the highly suspected ones. And we've sort of narrowed in on the possibility of them having pelvic venous insufficiency. I don't necessarily look for a pelvic venous compression syndrome until I get to angiography. So, that was a little bit long-winded to say I don't require imaging. I really base it on a clinical diagnosis. That's sort of, if you ask me this in a year or even two, you may get a slightly different answer. I think, where I am in my fibroid practice and my UAE practice is, I'm very kind of set in my ways. When it comes to pelvic venous disorders, I think we're constantly learning, about the disease process. So maybe as we do that and we have more understanding of it, I may adapt to that, a different type of pattern with imaging. But right now, I just haven't found it to be incredibly useful unless you're doing the scanning yourself with ultrasound, which sometimes is not feasible.
I'm getting a text here from Rich suggesting that some reason why people do MRIs is just to exclude endometriosis or other causes, which was another question. So, and this is pretty far out, but do you know of any minimally invasive ways of treating endometriosis? Because that's another thing that women are presenting with in terms of to your clinic, maybe with pelvic pain. Have you heard of embolization of endometrial deposits or anything like that?
No, endometriosis might be just even one step harder in some ways to diagnose than pelvic venous disorder. It, as you know, as most of you know, you can see it on MRI at times, but it's not necessarily able to be visualized on MRI. So I don't do an MRI to exclude endometriosis. A lot of my patients that actually come to me have had a diagnostic lab for endometriosis. It's not uncommon by the time they get to you and the etiology of a vascular entity is brought up. I think it's a really interesting question about whether there's anything that we can offer in the endometriosis space. It's been on my mind, definitely. And whoever asked that question, I'd love to talk at some point because, just reach out to me because I don't have any grand ideas yet, but I think it's definitely something that we can be helpful with if we can find an imaging agent that identifies it well. I just don't think at this point an ablation technique or something of that nature can be useful because we have such a bad visualization of it.
Yeah, it's definitely something that we hear a lot from patients. Even my cancer patients tell me things like, I haven't had this much pain since my endometriosis. So I tell it's something that definitely stays with patients for their entire life.
Yeah.
So we're kind of winding down. Thank you so much. One of the questions, I think just some of the trainees wanted to hear a little bit about just, something brief about, what was your journey towards sort of leadership within the society, within your own, did you always know that early on that you wanted to be, for example, division director or anything like that? Or was that something that you kind of built and graduated to over your career and decided that was some challenge that you wanted to take? So a little bit.
Yeah, that's a great question.
Topic.
Yeah, no, I could keep that pretty brief. In both the society and in terms of leadership within my division, I did not know early on. And in fact, there are challenges that especially women, I think, and underrepresented minorities they face when in terms of leadership. And so I actually shied away from leadership in many ways. And so my journey was probably not uncommon for women in IR, but I was intimidated by leadership in both the society and within my organization. And I think it was really just very, very solid mentorship in a variety of flavors. So not just women in IR, but men in IR in my own institution and other places in the country, peer colleagues, trainees that really help you form your journey and figure out what it is that you want to do within your career. And it's again an evolution and process. It doesn't. At least for me, it didn't come as a very clear-cut decision until I took that journey. And so for me, the society leadership, again, was early introduction and great mentorship. So, I think it's good to explore all of those things as possibilities and keep the doors open just in case you decide you want to pursue leadership in something that you might might not have thought that you were interested in.
Thank you. That's very possible. One time for one last question, which is how hard do you look for this round ligament artery? I think this is someone who's you're saying, do you get all the way to the inferior epigastric looking for it, or how much do you chase this? Is this something where it's like you can't find the supply?
No, I did not go looking for it. When I've seen a round ligament artery, it's on an aortogram. It's very, very characteristic. It's often small, and you might not catch it on the periphery of your image, but it is extremely, like if you think the uterine artery is corkscrew or the ovarian artery is corkscrew, you've seen nothing until you see a round ligament artery. It is impressive. Look it up, just Google it. I should have showed one, but I didn't. I've seen it probably in my 8 years of doing this. I've seen it close to 10, I would say getting close to 10 times. So it's there. It does supply fibroids or other disease processes at times, but it's not incredibly common. But it's very, very characteristic. My trainees at UAB have already seen it. I think I've had 3 of them at UAB already in a year and a half. So it's there.
All right. Thank you. Any other comments, Allison and Sean, you want to add?
No, it was a really great talk. Thank you so much. And definitely topics that are very close to my own practice. One question I did have for you is, do you utilize superior hypogastric nerve blocks for your uterine artery embolizations? And do you have any comments or thoughts about that?
Yeah, I have great friends in other places that utilize it and swear by it. And I do think there's a lot of utility in it. I personally don't utilize it. And my main reason, it's these mentors, they really stick with you. Jim and I, when we were in practice together, we saw a couple of cases of complications from it. So patients who had seizures on the table, which I don't feel particularly equipped to care for, but also, women who it obviously very uncommon, but who had discitis or osteomyelitis from it. And I just always put it in the category of, this is a woman who came in with menorrhagia, but she's otherwise healthy, 50 years old or in her 40s, and it's an elective procedure. And so adding the risk profile of that, even though uncommon as these things are, it's just, for me, it's a step too far. But again, it's not a judgment, and I definitely support my friends and colleagues who utilize it, because I think it's an incredible technique for getting patients comfortable and home in the same day. But I've just adapted my medication profile to be able to do that in the majority of cases.
Thank you very much, Dr. Caridi, for joining us. Sorry, Steve, I just have a quick question for adenomyosis embolization. Do you use the same endpoint for your spheres, like the 5-beat method? Or, because I remember you were saying when you were going over the cases that you sort of modulated it because you thought there was adenomyosis there.
Yeah. I go to a closer degree of stasis with adenomyosis, as has been suggested in the literature and by colleagues who see a lot of adenomyosis. And I also use smaller beads. So typically my range, not product dependent, but is somewhere in the 500 to 700 range for fibroids. And with adenomyosis, I use somewhere in the 300 to 500 range. It's based very lightly on the step-up protocol, if you've read about that. But you always have to remember the step-up protocol was done with PVE, which, or not PVE, PVA, which is, of course, acts as a larger agent. Mm-hmm. So even though they started in the 100 to 300 range with that, you have to remember that, when you're using microspheres, you don't probably want to jump down quite as low as that. So, but everybody, some of the experts in adenomyosis, like John Lipman and Mondo Kim and different people, they've started to get to where I think a lot of individuals are not even stepping up anymore. They're just staying within that sort of lower range. And so I think there's a variety of different ways of doing it, but degree is a little bit more static and a little lower, our smaller size bead.
Thank you.
Well, on behalf of the PAIRS membership, just thank you again for coming. And we have a small honorarium that we'll be sending out to you, but hopefully next time we'll see you in person. But in any case, thanks again. It was a great talk, and thanks for being a leader in our field. And we hope to see you again soon. Take care, everybody.
Thanks for having me.
And next month, I believe, Sean, do you have the information on who's coming next? Is it
Janice Newsom?
I think Dr. Newsom's coming up from also from down south. We seem to be picking a lot of Southerners lately.
I'm also a director of her division.
That's right. That's right. All leaders. It's how we roll.
Yeah. You should definitely attend that. It will not be boring. She's a wonderful, wonderful speaker.
Yeah, she's a great. We actually had her up here for grand rounds at Penn last year in fall or so. So yeah, she's a great speaker.
Awesome.
So, but thank you again, and we really enjoyed having you. So take care, everyone.
Thank you so much. Good night, everyone.
Thank you.